I don't think that our speaker today really needs an introduction, but we have decided to try to introduce everybody, even though they're well known to the institution. Bob Sandler has been here quite a while, and I think most of you know him as the division chief in gastroenterology and hepatology. He's built an international reputation in many areas, including research in the prevention of colorectal cancer, among others. I'm also in all of the way the GI division has built its clinical programs. I think we've learned to depend on GI to be there, and they always are, and help us quickly to get through our clinical problems. And I guess that's where I've interacted the most with the division. But at any rate, the other thing I should mention is Bob is the president-elect of the AGA. I think that's just another indicator of his national and international prominence. So without further ado, I'll let Bob talk about cancer prevention, colorectal cancer prevention.
Thank you. I'm going to talk about preventing colon cancer. And when I talk about prevention here, I'm talking about primary prevention. That is preventing people from getting colon cancer in the first place. I'm not talking about screening or early detection. And the thesis that I'm going to advance is that colon cancer is a preventable disease. And what I'll do, the way I've organized this, is during the background section, I'll place the problem of colon cancer in context, and then I'll tell you why I think colon cancer is preventable. And then in the next 45 minutes, I'll tell you how to do it. And the things that I will discuss are things like diet, lifestyle, medications, and then I'm going to end with some practical, sensible recommendations that you could share with your patients. The strategy that I'm going to use is that I'm going to focus almost exclusively on new information. That's why this is called Colon Cancer Prevention 2007. Most of the papers that I'll tell you about were published in the past couple of years. And in the spirit of evidence-based medicine, I'll actually provide you with the primary reference on which I've based these recommendations. And the other thing I'm going to do is I'm going to shamelessly show you studies that we've done at UNC because we've done a lot of this research here. Colon cancer is the second leading cause of cancer death in the United States. More people die from colon cancer than every other cancer except for lung cancer. More people die from colon cancer than breast cancer or prostate cancer. Your patients don't know that because breast cancer and prostate cancer have better public relations departments. In 2007, there will be about 154,000 new cases and about 52,000 deaths. I want you to remember this number because I'm going to come back to it on the very last slide. Colon cancer is an equal opportunity cancer. It affects both men and women. You can see it's the third most common cancer in men, and it's the third most common cancer in women. But because women don't get prostate cancer and men don't get breast cancer, that accounts for the fact that colon cancer is the second leading cause of death. Interestingly, there's striking geographic variation in this cancer. The disease tends to be common in Japan, Australia, New Zealand, and it's uncommon in Asia, Africa, and South America. There's about a 9-fold difference in the incidence of colorectal cancer around the globe. Even more importantly, when people migrate from a low incidence area such as Southeast Asia to a high incidence area such as the United States, their rates of disease go up within one generation. And what that means is that there must be something in the environment that's responsible for colorectal cancer. And you remember I showed you this 9-fold difference in incidence. That means that there's something in the environment that's responsible for about 80% of colorectal cancer. And when I talk about environment here, I'm not talking about air pollution or water pollution. I'm talking about things like diet and physical activity and medications, things that we could manipulate. And the implications of this are very important, and that is, if we could figure out what it was in the environment that was responsible, we could prevent about 80% of colorectal cancer. Well, what is it in the environment that's responsible? There have been a huge number of studies that have looked at diet. And the reason for that is fairly obvious. When people change cultures, one of the things that changes most strikingly is their diet. In addition, let's face it, what we eat ends up in our colon. So as you might imagine, there have been a ton of studies that have looked at diet and colorectal cancer. One of the earlier studies looked at meat. This is an old study that plots on the x-axis per capita meat consumption in grams, and on the y-axis the rate of colorectal cancer. And the individual dots are different countries, so New Zealand, the United States, Canada, and you can see there's a very good correlation between meat consumption and colorectal cancer. I left out a few dots, so that's why it looks better. Now, when I show that slide, I always show this other slide. And this is real data, comes from Germany. And in blue, we have newborn babies born in Germany. And in red, we have pairs of brooding storks. And you can see there's a very close association that you recognize is not due to cause and effect. Having said that, I'll point out that just about every study that has looked at meat has shown a good correlation between meat consumption and colorectal cancer. This is a study that appeared recently in JAMA. It was from a cohort that was followed by the American Cancer Society. It was a big cohort. There were 146,000 individuals. And what they reported in this study was that people who ate more red meat and processed meat were about twice as likely to get colorectal cancer. What is it about meat that's responsible? For a long time, people thought it was a fat content. And the idea was that when you eat fat, your gallbladder contracts to help you release bile that digests and helps you absorb the fat. And bile, when it gets into the colon, is irritating. It increases proliferation, and that was thought to be the mechanism to increase the risk for cancer. It's a pretty good theory, but it's probably wrong. And one of the pieces of evidence that suggests that it's not actually fat that increases the risk of colorectal cancer comes from this important paper. This was from the Women's Health Initiative. And in this study, women were randomized to a very low-fat diet or a conventional diet. And as plotted here, you can see that the women who were randomized to the low-fat diet were not less likely to get colorectal cancer. Now, this study has been criticized for all sorts of reasons, but I think that in combination with a large body of epidemiologic studies, most people currently do not think that it's fat that's responsible for colorectal cancer. If it's not fat, what is it? Well, it could be due to the fact that when we cook meat at high temperature, we produce heterocyclic amines and polyaromatic hydrocarbons that are carcinogenic. And when you cook your meat that looks like this, where it's black on the outside and brown on the inside, you produce more of these potentially carcinogenic compounds. And we and others have actually done some research that suggests that when your meat looks like that, you increase your risk for colorectal cancer. So we know in 2007 that meat increases the risk for colorectal cancer, and we believe that it's a consequence of the way we cook and prepare meat that's responsible for the increased risk. The implications of that are pretty clear. Eat more chicken. Okay. I'd next like to talk about fiber, and this is a picture of Dennis Burkitt. Dennis Burkitt was a surgeon and a geographic epidemiologist who was working in Africa, and he was a very astute observer. Burkitt's lymphoma is named after this man. And one of the things that he observed was that colorectal cancer was virtually unheard of in Africa. And he made the leap that the decreased risk for colorectal cancer in Africa was due to the increased consumption of fiber in the diet. It's kind of a neat hypothesis, and you can come up with a lot of mechanisms to explain why eating a high-fiber diet might decrease the risk for colorectal cancer. For instance, fiber can dilute carcinogens and it speeds transit. And there are a whole bunch of very clever hypotheses to explain why fiber might decrease the risk for colorectal cancer. The problem is that's probably not correct. And the best evidence to suggest that fiber is not actually protective against colorectal cancer comes from this study. This was a study where they pooled the results from 13 prospective cohort studies. Collectively, these studies had 725,000 people. This is a huge analysis, and the results are shown in this forest plot. These are the individual studies, and this is the summary estimate, and you can see that there is very little or no evidence that eating a high-fiber diet decreases the risk for colorectal cancer. So in 2007, we don't think that fiber protects against colorectal cancer. Just because fiber doesn't protect against colorectal cancer does not mean that fiber-containing foods might not be protective. There's a large body of evidence that has looked at fruit and vegetable consumption, and just about every single one of those studies has shown that people who eat more fruits and vegetables are less likely to get colorectal cancer. It turns out that plants and vegetables contain a large number of chemicals called phytochemicals, and these include things like zeaxanthin, carotenoids, lycopene, lutein. They're the chemicals that give plants and vegetables their characteristic color. It turns out that natural product chemists have isolated over 100 compounds from the plant kingdom that are either anti-mutagenic or anti-carcinogenic. And they include things like carotenoids, terpenes, plant phenols, thioethers. There's even protease inhibitors in plants. And what's exciting to me about this line of research is that many of these compounds are very potent. And the reason that's attractive is that means that if we could figure out which chemicals were protective, we could package these in the form of a capsule and give them to our patients to prevent them from getting colorectal cancer. The reason that's important is you know that it's impossible for us to get our patients to change their diet. But if we could package this as a capsule, currently over 50% of Americans take a vitamin or a mineral supplement. And so if we knew the right agent, we could give it to people in an easily consumed form and thereby decrease the risk of getting colorectal cancer. There's actually some evidence that that might work. And I'll show you this study. I'm not proud to show this study because it's really almost a case report, but it's extremely clever and it serves as a proof of principle. And in this study, the investigators gave patients with familial polyposis curcumin and quercetin. Curcumin is the yellow spice that's found in Indian curry. It's an antioxidant, but it also can inhibit NF-kappa B and interfere with signaling. And quercetin is a plant phenol that is an antioxidant. And these investigators gave a small number of polyposis patients a combination of these compounds, and as you can see, the number of polyps decreased. And on the right side, I've shown a photograph. I don't know how well it shows up, but there's a polyp here and it's gone on the treatment. Again, a very small study, but I think it proves the fact that someday if we could figure out which of these phytochemicals might actually be protective, we could give them to our patients and decrease the risk of getting cancer. I'd next like to talk about calcium. And this is a paper that we did a few years ago in which we randomized patients who had polyps to either calcium carbonate or a placebo. We followed them over 3 years to see if those who were randomized to calcium would be less likely to develop new polyps over that interval. And what we discovered was that there was a 19% decrease in the number of subjects with one or more polyps and a 24% decrease in the mean number of polyps per subject. Based on this study, the Wyeth Company produced this product called Caltrate Colon Health. This is for people who want to protect themselves against polyps after a polyp resection. What's interesting to me is Caltrate Colon Health is exactly the same as regular Caltrate. It's just calcium carbonate. But by putting it in this box, they could capture a market segment. They could get shelf space in the pharmacy and the drugstore, and they could sell these pills. This is an interesting intersection between commerce and science. Now, you may have seen this study. This appeared in the New England Journal, and this is another study from the Women's Health Initiative. One of the arms of the Women's Health Initiative randomized women to getting calcium and vitamin D or a placebo. And the results with respect to colorectal cancer are shown in this graph. You can see that those who were randomized to calcium were not less likely to get colorectal cancer than those who got placebo. The problem with the study was there were a number of problems with this study. First of all, those who were randomized to calcium were often non-compliant. And those who were randomized to placebo often took calcium off study. And the baseline calcium consumption of the study subjects was relatively high. And finally, and probably most importantly, they may not have followed the patients long enough. So although this study is negative, I think that the preponderance of evidence in 2007 suggests that calcium and vitamin D can decrease the risk of polyps and decrease the risk of getting colorectal cancer. A very exciting paper appeared on Christmas Day in 1996 about selenium. This paper was, the lead author for this paper was a fellow named Larry Clark. Larry Clark was actually a graduate of the UNC School of Public Health. And Larry had this idea that selenium would prevent skin cancer. In order to do this study, he rounded up a bunch of dermatologists, and they randomized patients to 200 micrograms of selenized yeast, a selenium-containing compound, or a placebo, and they followed them over time to see if they could detect a decreased risk in skin cancer. And what they found was that selenium did not prevent skin cancer. It had absolutely no effect whatsoever. However, it prevented every other cancer. It prevented esophageal cancer, stomach cancer, pancreas cancer, liver cancer, and here's prostate cancer. Here's the results for colorectal cancer. It decreased the risk of colorectal cancer by 60%, really a strong effect. Unfortunately, this hasn't actually been followed up yet. There is a study in the field that will look at this, but I think selenium could someday be a very useful agent because it's really cheap and it's relatively safe. For a long time, people have felt that antioxidants would prevent us from getting bad diseases. And the idea was logical, and that is that an antioxidant would quench free radicals, it would decrease DNA damage, it would prevent mutations, and would prevent people from getting cancer. It's a nice hypothesis, but it's probably incorrect. And what I've done here is shown you a graph from a paper that looked at the effect of antioxidants on a variety of GI cancers. This is not just colon cancer, this is a variety of GI cancers. But again, you can see from the summary evidence is that there's no evidence whatsoever that antioxidants can decrease the risk of getting GI cancer. The same holds for colorectal cancer. Antioxidants don't work. You're, I'm sure, painfully aware of the obesity epidemic in the United States. This is a graphic from the CDC. Back in 1991, about 10 to 15% of the United States was obese, and now in 2007, the number is in excess of 25%. This is where things are headed. So it turns out that obesity is a risk factor for colorectal cancer. There have been a large number of studies. This is a report from a cohort of individuals that was followed by investigators at the American Cancer Society. And in men, the men who had a BMI greater than 35 were almost twice as likely to get colorectal cancer. The literature is quite consistent about obesity, and it turns out that obesity is more of a risk factor for colon cancer in men than it is in women. The reason for that is not certain, but investigators have begun to look at fat distribution in order to understand the risk for colorectal cancer. In this report from the Framingham cohort, the individuals looked not only at body mass index, but they also looked at waist circumference, and they discovered that waist circumference is a stronger predictor of colon cancer risk than body mass index. And the reason may be related to the fact that abdominal obesity is associated with metabolic syndrome. There's relative insulin resistance. There's higher circulating levels of insulin. Insulin is a growth factor, and that may in fact be the reason why obesity, particularly abdominal obesity, is associated with colon cancer. And it may also explain why the risk for obesity is greater in men than women, because men are more likely to have abdominal obesity than women. The next topic I'd like to talk about is physical activity. And here's a sort of a pudgy pigeon and some sort of shorebird discussing physical activity. And a very nice paper was published a number of years ago from a cohort called the Male Professionals Cohort Study. This was a cohort of health professionals, including optometrists and pharmacists and veterinarians. And what the investigators did is they interviewed the men at the beginning of the study about their physical activity, and they followed them over time to see if those who were more physically active would be less likely to get colorectal cancer. The results are shown here. The measure of physical activity is the MET, or the metabolic equivalent. And the way the slide works is these are 5 categories of physical activity, from the lowest category to the highest category. And you can see that men in the highest category of physical activity were about 70% less likely to get colorectal cancer. And looking at this p-value, it's not likely that this is due to chance. And they control for all the usual suspects, and they control for obesity. So this isolates, as well as possible, the individual effects of physical activity. There are a lot of studies that have looked at physical activity, and every single one of them has shown that people who are physically active are less likely to get colorectal cancer. And the reasons for that are uncertain. So I've shown you that obesity is a risk factor for colon cancer, and I've shown you that physical activity is protective, and tall, thin people like Dr. Goldstein are feeling pretty smug. Well, height's a risk factor for colon cancer. And if you're more than 73 inches, you're twice as likely to get colon cancer than a short person like me. And the reasons for that are completely mysterious. The authors of this paper speculated that maybe tall people have longer colons, and there's more cells at risk. But the GI folks in the audience who do colonoscopy on little short women can tell you there's very poor correlation between how tall you are and how long your colon is. Probably the real reason has to do with nutrition. And it turns out that your achieved adult height is directly related to your nutrition when you're an adolescent. And the proof of that is, if you look at the offspring of migrants from underdeveloped countries, the offspring are often taller because they have adequate nutrition when they're teenagers. For somebody like me who does nutritional studies and asks people what they ate last year, a slide like this is sort of bad news because it might be the diet that they ate when they were 13 and not the diet that they ate last year. Your patients all think that constipation increases the risk for colon cancer. This was the way we used to treat constipation in biliousness 100 years ago. We don't treat much biliousness, but we treat plenty of constipation. And if you get on the internet, you'll find a ton of sites that where people want to give you enemas and things to clean out your colon because the toxins that are associated with constipation are supposed to increase your risk for cancer. And I'm here to tell you that constipation is not a risk factor for colorectal cancer. This is a very nice study from the nurses cohort. In this study, there were 85,000 women who were interviewed about their bowel habits. Gastroenterologists sort of enjoyed doing that. But at any rate, the reference group is a daily bowel movement, and those who had a bowel movement every 3 days or less were constipated. And you can see that those who were constipated were not at higher risk for getting colon cancer. They're actually at slightly lower risk. And I think that there's very good evidence from a number of studies that constipation is not a risk factor for colorectal cancer. I'd like to spend the rest of the time talking about chemoprevention. And chemoprevention is defined as the use of specific chemical compounds to prevent, inhibit, or reverse carcinogenesis. These agents are required to have minimal toxicity because they're used for a long period of time in healthy people. And you can think of a continuum. So on one end of the continuum, we have healthy people, and on the other end, we have cancer patients. We're all familiar with chemotherapy. That's what we give to cancer patients. We give it for a short duration, and because these people have serious, life-threatening illness, we're willing to accept a ton of toxicity. But on the other hand, we have healthy people who might be candidates for chemoprevention. And because we need to give chemoprevention for a long time, and because these people have no illness, we can accept minimal or no toxicity. And as I begin to talk about the individual agents, it'll become very clear to you that the agents that we have available today are probably too toxic to use for a long period of time in healthy people. The first agent I'll tell you about is aspirin, and this is a paper that we published in 2003 in the New England Journal, where we randomized patients with previous colorectal cancer to one adult aspirin, 325 milligrams a day, or placebo, to see if we could prevent them from developing polyps, which are the precursors to colon cancer. And the reason we selected patients with previous colorectal cancer is we reasoned that they had already demonstrated that their mucosa was at risk, and it might be easier to detect an effect in a high-risk population than in an average-risk population. And that hypothesis was confirmed. What we discovered was that compared to the placebo group, those who were randomized to aspirin were significantly less likely to get colorectal adenomas during the follow-up period. The adjusted relative risk was 0.65, suggesting that we could decrease the risk of getting polyps by about 35%. In fact, the study was stopped early by the Data and Safety Monitoring Board because we demonstrated a statistically significant difference during a planned interim analysis. We published another paper in the same issue of the New England Journal, and this paper differed in two respects. First of all, this study randomized patients who had previous adenomas. The previous study that I told you about, the patient had previous cancer. And secondly, this study featured two different doses of aspirin, 325 milligrams and 81 milligrams. And the results of the study are interesting and somewhat perplexing. What we discovered was those who were randomized to the low-dose aspirin were significantly less likely to develop an adenoma. They were about 19% less likely. But those who were randomized to the higher dose, in fact, did not have a decreased risk. So the dose response went in the wrong direction. And this was true overall. It was also true when we confined ourselves to advanced lesions that are defined as polyps that are a centimeter or size and greater or have advanced atypia. Again, we see that the lower dose decreased the risk, the lower dose of aspirin decreased the risk of getting an advanced polyp, but the higher dose didn't. And it's impossible for us to fully explain this dose-response relationship. There was a paper that was published in JAMA in 2005, another randomized controlled trial of aspirin. This is called the Women's Health Study. It was a randomized controlled trial of 39,876 women, so it was a very large study. And on this graphic, the authors have presented the results for a variety of different cancer outcomes: total cancer, breast cancer, colon cancer, and lung cancer. And in no case were women who were randomized to aspirin less likely to develop a cancer outcome. The problem with the study is the dose was 100 milligrams every other day, which is really a low dose. And I think most of us believe that the dose was too low and the follow-up was too short to demonstrate a protective effect of aspirin. I think there's widespread agreement based on the randomized controlled trials and the epidemiologic studies that aspirin can reliably decrease the risk of getting adenomas and cancer. Now, just because it works doesn't mean that we should be giving it to our patients. And the U.S. Preventive Services Task Force weighed in on this topic this year in the Annals of Internal Medicine. And they recommend against the routine use of aspirin and NSAIDs to prevent colorectal cancer in individuals at average risk for colorectal cancer. If you want to read the gory details about why they came up with that recommendation, you can read the companion paper that was also published in the Annals. But to give you the bottom line, the balance of benefits to risk does not favor chemoprevention in the average risk individuals. As I'm sure you know, aspirin, even in low dose, can be toxic. Even one aspirin a day can increase your risk of getting a gastrointestinal bleed or a hemorrhagic stroke. And because we're giving aspirin to average risk patients, then it doesn't really make sense to give it to prevent colorectal cancer. People often ask me what I would do because I've been involved in some of these studies. And my recommendation would be to limit recommendations for aspirin to individuals who would benefit from the cardiovascular protection. For example, people with elevated lipids or hypertension or diabetes. There's a lot of those people out there who should be taking aspirin who aren't. And those are the people we should be recommending aspirin to. And we also might recommend it to people who are at very high risk for colon cancer, for example, those with large numbers of polyps or previous cancer. But we should not be recommending aspirin indiscriminately to average risk people. The reason we don't want to use aspirin is because it's toxic. And if we had a safer alternative that also prevented cancer, that might be a good option. That was a motivation behind developing the COX-2 selective inhibitors. There are two isoforms of cyclooxygenase. There's COX-1 that's constitutively active, and it produces a prostaglandins that protect our gastric mucosa and they keep us from getting an ulcer. And there's COX-2 that's inducible, and it produces a prostaglandins that mediate pain, inflammation, and cancer. If we could selectively inhibit COX-2, we might be able to prevent people from getting cancer, but at the same time preserve the prostaglandins that would prevent them from getting an ulcer and bleeding to death. So that's the idea. And as you might imagine, there have been studies looking to see whether the COX-IBs would decrease the risk of getting colorectal neoplasia. This is a paper that we published in Gastroenterology last year. And in this study, we randomized people to rofecoxib 25 milligrams once a day. There were two other COX-IB studies. The first one is a study called the APC study. And in this study, the patients were randomized to two different doses of COX-IB, celecoxib, 400 milligrams and 800 milligrams. And in the PRESAP study, there was one dose of celecoxib, 400 milligrams a day. And I summarized the results of all of these studies on this graphic. It's a very simple graphic, and I've constructed it this way for the following reason. It very clearly demonstrates that in every case, those who were randomized to COX-IB were less likely to get a recurrent adenoma than those in the placebo group. However, I think you can also see that although these drugs were effective, about 40% of the people still had an adenoma at the end of the trial. So although you can protect people from getting an adenoma, 40% of them are still going to have one at the end of the study, and you still need to do colonoscopy. So the benefits of these agents are somewhat questionable, I believe. More importantly, as I know you're aware, these drugs are also toxic. And this is a paper that we published where we published this paper first, actually, where we reported on the cardiovascular events that are associated with the use of rofecoxib. And what we found was that over the course of time, those who were randomized to rofecoxib were significantly more likely to develop a confirmed serious thrombotic event, heart attacks, strokes, than those who were randomized to placebo. And it was on the basis of this study that our trial was stopped and the drug was taken off the market. The study also gave us an opportunity to look at the effects of coxibs on the gastrointestinal tract. The reason these drugs were developed in the first place is that conventional NSAIDs can increase the risk of getting an ulcer and getting GI bleeding. And the idea was that by using these selective agents, we could prevent people from getting ulcers. During the registration trials, when these drugs were coming to market, the studies used an active comparator. They used a coxib compared to naproxen or one of the other, diclofenac or one of the other NSAIDs. And in this chemoprevention study, half the people got a coxib and half the people got placebo. And when we looked at the effect of coxibs compared to placebo, we found that those who were randomized to the coxib were about 3 times more likely to get what we call in the industry a pub. A pub is a perforation, ulcer, or bleed. So when you compare these drugs to placebo, as would be the case for chemopreventive purposes, they aren't very safe. They increase the risk by 3 times. And when we broke it down into gastric ulcer, duodenal ulcer, and upper GI hemorrhage, the results were pretty incredible. So people were about 20 times more likely to get a duodenal ulcer if they were randomized to coxib versus placebo. So I think based on toxicity, there's no way we would possibly consider using a coxib for chemoprevention. There's an interesting agent called exasulin. This is sulindac sulfone, and although the name includes the word sulindac, which is an NSAID, sulindac sulfone actually has a unique mechanism of action. It does not, in fact, inhibit prostaglandins. And in this particular study, the authors used a completely different design. Usually what we do with these chemoprevention studies is we colonoscope people, remove all the polyps, and then place people on an agent to see if we can prevent them from getting another polyp. What these authors did is they left the polyps in place and they measured them at the beginning of the study, and they looked to see whether the agent would cause the polyps to shrink. And this is what they found. So on the left, we have the percent change in median polyp size, and you can see that those that got the higher dose of exasulin, the polyps did in fact shrink. And they also had a measure called disease progression, which was defined as increase more than 25% in polyp size. And once again, the higher dose of the exasulin was associated with decreased progression. So the drug clearly worked. The only problem was it was toxic. It was toxic to the liver. And because of that liver toxicity, this is not a viable agent. I mentioned before that we did a randomized trial of aspirin to prevent colorectal adenomas. Well, that wasn't actually all we did. We actually did a study using a factorial design. And in the same study, we measured the effect not only of aspirin, but also of folic acid. And we reported the results of the folic acid arm of the study in JAMA this July. In this study, individuals were randomized to 1,000 milligrams of folic acid or placebo to see if the folic acid would decrease the risk of getting an adenoma. And the study was motivated by a large number of epidemiologic studies that consistently showed that people who consumed more folic acid were less likely to get colon cancer and colon adenomas. And what we found is shown here. So again, we hypothesized that those who got folic acid would be less likely than those who got placebo to get an adenoma. But in fact, what we found was those who were randomized to folic acid were more likely, these are percents, were more likely to get an adenoma. And this is the graphic. And when we looked at advanced lesions, remember advanced lesions are big polyps and polyps with atypia, those who were randomized to folic acid were significantly more likely rather than less likely to get an adenoma, and this was statistically significant. So rather than demonstrating a protective effect, we demonstrated what in fact might be a harmful effect. Those of you who have read the cardiovascular literature may have seen this study. This is called the HOPE study, sort of a bad name for the study. The hope was that if you lowered homocysteine by using folic acid and B vitamins, you could prevent people from getting cardiovascular disease. And what they found was, in fact, you could lower the homocysteine, but you didn't, in fact, decrease the risk of getting cardiovascular disease. So folic acid doesn't look like it prevents cardiovascular endpoints. And if you read this paper carefully, there's information about colorectal cancer risk. And what it suggests, these are not statistically significant, but there's a hint that folic acid might actually increase the risk of colorectal cancer. So I think in 2007, it's pretty clear that folic acid does not decrease your risk of getting colorectal cancer. There's a really neat study that was published last month in a journal called Cancer Epidemiology, Biomarkers, and Prevention. This is called a hypothesis. It's called a hypothesis. And what the investigators did, this is a simple idea. They plotted the incidence of colorectal cancer in the United States. So that's this curve. In 1996, the United States began to fortify the food supply with folic acid to decrease the risk of neural tube defects in pregnant women. And it worked. There was a decrease about 25% to 50% in neural tube defects in pregnant women. But what happened is shortly after they fortified the food supply, there was an inflection in this curve. There was an increase. The curve, the incidence curve for colon cancer had been going down. This is where they fortified the food supply, and there was this bump in the curve. And on the right, I have Canada. Now, the healthcare system in Canada is completely different, right? They have a different financing system, but we see the same thing in Canada. And interestingly, in Canada, they began to fortify the food supply 1 year later, and the curve is shifted over by 1 year. Now, remember this slide I showed you before about ecological fallacy? There's reasons to think that this could be coincidence, but I think the fact that we see the same thing in the United States and in Canada, and the fact that the curves are shifted by a year, which is when the food supply in each country was fortified, at least raises a possibility that there may have been some unintended consequences of fortifying the food supply with folic acid. I think we need more research on this area. The next agent I'd like to talk about are postmenopausal hormones. This is another study from the Women's Health Initiative. In this arm of the study, women were randomized to estrogen plus progestin compared to placebo, and the women who were randomized to get estrogens were about half as likely to get colorectal cancer. A striking effect, and there's some epidemiologic studies that show the same thing. Unfortunately, this arm of the study was actually stopped because although these agents decreased the risk of getting colorectal cancer, they increased the risk of getting heart disease and certain cancers, so the study was actually stopped. But there's pretty good evidence that this is one more agent that's good for the colon and bad for the rest of the body. The problem I have as a gastroenterologist is that when I trained, we used to look through these scopes, so I have tunnel vision, and I tend to think about the colon. But what you have to remember about chemoprevention is that these agents work everywhere in your body, and you can't just focus on one organ. And this study is a good example of an instance where it worked in the colon, it was good for the colon, but it was bad for the heart. The last agent I'm going to talk about are the statins. And this was a paper that came from Israel. This last guy, Gad Renner, was my first doctoral student. And in this somewhat surprising study, it was a case control study. They had about 2,000 colon cancer cases and 2,000 controls. And they reported that those who took statins for more than 5 years were about half as likely to get colorectal cancer. Now, that's pretty exciting because lots of people take statins. The problem is it's probably not true. And there was an excellent study that was done in the United States. This was done in New England, a hospital-based case control study. And in this study, there was no evidence that statins decrease the risk of getting colorectal cancer. We've done some studies at UNC that show the same thing. So I don't believe that statins actually decrease the risk of getting colorectal cancer. Well, I've shared a lot of information. Is there some way that we can briefly summarize all those findings? And I would make the following recommendations that you could share with your patients. First of all, eat a sensible diet that's high in vegetables and fruits and limit red meat. Avoid obesity, trying to maintain a BMI less than 25 kilograms per meter square. Engage in regular physical activity. Consider supplements with calcium plus vitamin D. I've shown you evidence that aspirin, the COX-2 inhibitors, exosulin, postmenopausal hormones are toxic. Statins and folic acid don't work. And as the chief of gastroenterology, you need to remind your patients to get a colonoscopy. Steve Kaiser here. Now, I'll end with this. So this is a picture of Kenan Stadium. And you remember on my third slide, I showed you that about 55,000 people will die from colorectal cancer in the United States in 2007. When this photograph was taken, Kenan Stadium held 55,000 people. That's how many people are going to die this year in the United States from colorectal cancer. If we could get people to adopt the sensible recommendations that I've shared with you, there's reasons to think that we could decrease the risk of colorectal cancer by 70%. And since your patients are not likely to do that, and they get a colonoscopy, we could also probably decrease the risk of colorectal cancer by 70%. So we have a lot of work to do, so let's get busy. Thank you.
Folic acid indicates that the total incidence is diminishing.
It is. And so the question is why? Now, as a gastroenterologist, I'd like to say it's screening colonoscopy, but the curve started going down before we started doing colonoscopy. So there, I think, is something in the environment that's responsible, something that we're doing. And I have some ideas about that, but the honest truth is we don't know why that is.
So Bob, there was a study done in the GCRC a number of years ago using cruciferous vegetables to see whether if you ate all that black meat, you could then reduce the risk, or at least reduce the availability of those various toxic stuff.
Right, so cruciferous vegetables contain isothiocyanates and other chemicals that are probably anti-carcinogenic. And there's some observational studies that suggest that if you eat a lot of broccoli and cauliflower and members of that vegetable family, you're at less risk of getting colorectal cancer. And probably partly by detoxifying xenobiotics that are found in well-cooked red meat. I don't remember what that study showed. Do you?
No.
I'm probably an author on it, too. I might be an author. I'll have to go check.
What's the mechanism of selenium removal, right? It's an antioxidant.
Right, so selenium is an antioxidant, but it may have other effects. It may have immune effects and some other effects. So I don't think we fully understand what the mechanism of selenium might be. Yes? Right. It's less invasive and it may be less expensive. In gastroenterology, we have this expression, you know, do you want a virtual colonoscopy or do you want a real colonoscopy? So the study was carefully done, and what they report was that 37% of people that had an optical colonoscopy had a polyp, and 12% of people with a virtual colonoscopy had a polyp, of whom 8% actually underwent a colonoscopy. And so if you read the paper carefully, what they say is, well, what we really want to know about are big polyps. And we in gastroenterology feel that you don't just develop a big polyp today. It starts as a small polyp, and if you could remove that small polyp, you might be able to decrease the chance of getting a bigger polyp later on. My take on it is the following, and that is, we want people to get screened for colorectal cancer, and if people would like to have a virtual colonoscopy, and if that's what it takes to get people screened, we're fine with that. I think as a profession, we need to get people screened. It's not reimbursed, so your patients aren't, and there aren't very many people that do it, so it would be hard to find one. That's more than you wanted, right?
And then once you find the polyp, you got to have a colonoscopy.
Right. So some of your patients may find that they would prefer one definitive test than having a colonoscopy, having a virtual colonoscopy, finding a polyp, and then needing a regular colonoscopy. And then some of them won't be completely happy with the fact that you tell them, well, if your polyp is less than 5 millimeters, we're not going to tell you about it. Come back in a few years, we'll do this again and make sure it hasn't grown.
Well, but they're currently limiting the images on virtual colonoscopy to the colon. The reason I'm asking that is the whole column of all the extraneous findings and what that's doing to the need for further testing.
Yeah, so that's a good point. So it's cheaper if you don't have something else, some incidentaloma that they want to biopsy. So that if you look at that paper, they found cysts and things in livers and in kidneys quite commonly. Occasionally you find something that you want to know about. You may find a cancer. There were a few cancers that were found in the rest of the abdomen when they did the CT. So it's not clear. But I think that the point, though, is that if you image the entire abdomen, you look at the entire abdomen. Yeah, gastroenterologists used to say that if you got a CT, you were going to get cancer from the radiation, but they've actually lowered the dose quite considerably, and although they don't, in this paper, describe what the dose is, the thought is that the risk is not zero, but it's pretty low, the radiation risk. Okay, thanks for coming.